Hello, everybody. My name is Stephanie Christian, and I'm a DNP student from Maryville University. And I am going to talk to you today about my project, which is improving advanced directive completion in hospitalized patients. My DNP project committee was my chair, Dr. Tara Harris, second reader, Dr. Jennifer Brunworth, and community member Michelle Hunterdos, nurse practitioner for palliative care at the hospital that I work at. So a little bit of background on my project. As we all know, end of life is an inevitable phenomenon, and every person should have the right to decide their own preferences on end of life care via the use of advanced directive documents. So advanced directives include a living will and a durable power of attorney. And a living will is a document that directs the care team on patients' wishes regarding life-sustaining treatment, and that can include things like cardiopulmonary resuscitation, organ donation, artificial nutrition, tracheostomies, dialysis, things of that nature. A durable power of attorney is a person that is designated by the patient to make healthcare decisions for them when they are no longer able to do so. And through the research, I did find that 1/3 of U.S. adults have advanced directives on file, and less than 50% of terminally ill individuals have these documents, which I thought was a very startling statistic. So the purpose of this DNP project is to improve and standardize the way that advanced directive conversations are had with patients in the hospital and hopefully eventually in the clinics, but this focused specifically on hospitalized patients. And my end goal was to improve the number of advanced directive documents that were completed in hospitalized patients. So the specific aims of the project were to create fairness and equity in the realm of advanced care planning. At the facility that this project was implemented, if a staff nurse did not have proper training or education regarding what advanced directive documents were, the patient did not receive adequate education. And the same was true for the opposite. If a nurse was super well versed in advanced directives and care planning and things like that, the patient got a really excellent education and had a better chance of getting those documents filled out because they were better educated and more able to understand what they were signing up for. And all patients do have a right to receive a quality education regarding advanced directives, and the thought was that if I created a standardized education, that this would ensure that justice and equality. So in regard to the literature review, I started with the Maryville online database and Google, which yielded a lot of different articles that were utilized. And the search was limited to English language, full text, peer-reviewed articles that were published within the last 10 years. So key phrases that I utilized were advanced directive completion in hospitalized patients, encouraging advanced directive completion in hospitalized patients, advanced directives and powers of attorney in intensive care units. That was obviously not all, but those were where I located the majority of my articles using those phrases. So what I found overall in my literature was that patients are often quite resistant in having these honest conversations regarding the end of their life, especially in the hospital due to death-denying culture. And many healthcare providers either feel uneducated about how to have these types of conversations with their patients. And advanced directives can also increase referrals to both hospice and palliative care, which does improve quality of life and also, most importantly, I think, healthcare provider compliance with end-of-life preferences. You can't do what the patient wants if you don't know what they want. So that is a very important part of having advanced directives. They also allow patients to retain as much autonomy as possible by writing out exactly what they want. And most individuals stated throughout the research that they would prefer to die at home rather than in the hospital and hooked up to machines. So I think we should allow them that opportunity. And throughout this process, I wasn't able to really locate any articles that talked about any implementation of a specific standardized education that was actually provided to the patients directly, which was what my project ended up being centered around. So the theoretical framework that my project was based around was Lippitt's model of change. So this change theory created by Lippitt, Watson, and Wesley in 1958 created a 7-step model that centered around the role of a change process leader and the addition of a change agent. So for my project, I was the change agent in this scenario. So the 7 steps of this theory are as follows. Developing a need for change by diagnosing the change and establishing a change relationship. Assessing both capacity and motivation for change. Clarifying and assessing the change and determining the resources. Establishing the goals and intentions for the action plan. Examining possible alternatives. Transforming the intentions into change and maintaining that change, and generalizing and stabilizing change to ideally end the assistance of the change agent. So the hope for my project was that this is something that can continue to be utilized when I am not there behind the scenes, essentially pulling the strings and creating the standardized conversation, that it will just eventually be something that is implemented and can continue to be implemented in other healthcare systems across the country. So the design and methodology, this was an interventional study design with a pre-intervention chart review to assist with time management and ease of implementation. Unfortunately, as we all know, our projects were implemented during the pandemic, and we have all felt the nursing staffing shortages across the country. So making this something that the nurses were able to implement easily into their usual schedule was absolutely imperative. Participants all received the standard education or advanced directive education conversation format during the study period, and data was collected on whether patients completed advanced directives during their admission or did not. And the pre-intervention chart review just looked at the number of advanced directives that were completed on the unit in the prior month to the study period, making sure that they also met the same exclusion and inclusion criteria. So that inclusion and exclusion criteria were that, we'll start with inclusion. The participant had to be between the ages of 18 and 89. They must have been able to speak English fluently. And the nice thing about Epic was that I was able to see that easily in doing my chart reviews at the end to make sure everything was recorded accurately on the data sheets, because we have a little section on Epic where it says what language the patient speaks. They had to be diagnosed with a cardiac condition requiring telemetry monitoring. So heart failure, atrial fibrillation, non-STEMIs, STEMIs, things of that nature. They had to have been admitted to this telemetry unit between March 1st, 2022 at midnight through midnight on March 29th, 2022. And they had to actually listen to the standard advanced directive conversation. They had to have never had an advanced directive completed previously, and they could not have any cognitive disabilities that would prevent them from legally signing their own paperwork, such as dementia, delirium, alcohol intoxication, any sort of mind-altering substances. So exclusion criteria really were sort of kind of the opposite between of the inclusion. So obviously they couldn't be below 18 or over 89. They couldn't refuse to listen to the conversation. They couldn't be, mainly Spanish speaking, Arabic, anything like that. They couldn't have tested positive for any mind-altering drugs like methamphetamine, cocaine, things like that could impair their judgment. They also had to be medically stable, so if these patients were too sick to really be able to listen to the education, that excluded them. And if they had any advanced directives that were previously completed, they were also excluded from this study. So the sample size, it was a convenient sample that was obtained utilizing the previously discussed criteria. Participants were not aware of their participation in the study in order to control for bias, and no patient identifiers were used as a result of this study. So there ended up being 66 participants in the control group, which was the pre-intervention chart review in the month of February 2022, and 71 in the experimental group that all received this standard education regarding advanced directives. So I just wanted to include my charts for the analysis portion so you can see these. I won't go through each of these individually. I'll discuss it more at the end here, but I just wanted to include this in here so we could just see the statistical inputs. And same with this slide, and I'll explain that more when we move to the next one. So I use a z-test for two proportions, which would be beneficial in determining whether two variables are independent of one another. So seeing whether in the implementation of this standardized advanced directive education to the patient actually did result in an increase in the number of advanced directives completed in that particular population compared with the patients that did not receive the standard conversation in the pre-intervention chart review. So unfortunately, the data revealed that the patients that were exposed to the advanced directive conversation did not have statistically significant increase in the number of advanced directive documents being completed, with a p-value of 0.4253. And I think this was largely related to the fact that a minimum sample size of 154 participants were needed, and unfortunately, the study time period just did not allow for that to be possible. So the results of the study. So it was a 23-bed medical telemetry unit in a level 1 trauma center in the Midwest region of the United States. It was a part of a larger health system that spans several states in the Midwest, and the unit specialized in caring for patients with things like non-ST elevated myocardial infarctions, ST elevated myocardial infarctions, congestive heart failure, arrhythmias such as AFib, ventricular tachycardia, cardiac arrest, cardiomyopathies, pericarditis, myocarditis, endocarditis, pulmonary embolisms, things of that nature. Those are obviously not all inclusive, but those are the general population that we see on that particular unit. And like I discussed previously, the sample size needed was 154 to obtain a significance of 0.05, which was not obtained in either study group. The post-intervention data collection during the study included 71 participants, in which 6 of those participants did complete standard or advanced directives as a result of hearing the education, which resulted in a proportion of 0.0845. And the pre-intervention data collection included a group of 66 individuals, with 5 of those completing advanced directives while they were in the hospital without hearing the standard advanced directive conversation. So that resulted in a proportion of 0.0757. The z-test statistic on this was 0.1883 with a p-value of 0.4253, which was greater than 0.05, and therefore that was not sufficient enough information to suggest that there was an increase in the ratio from pre to post-intervention. And the achieved power of this study was 0.0722, which was also considered low in strength. So in regard to limitations, as discussed previously, the study did occur during the COVID-19 pandemic, which obviously brings its own challenges, especially with the high rates of staff turnover. Nursing burnout was also very huge, and the utilization of travel nurses. There was often travel nurses coming in, every other week, and they either did not receive an official formal education on how to do this, or they just didn't care enough to help out, which could have also happened. So mainly it was focused on the staff nurses on the floor that work there all the time, trying to help the travel nurses remember to get this project done. And I had wonderful nurses that I relied on and worked with that were there all the time. or at least they had worked there for several years and they were there at least 3 or 4 days a week, that were very instrumental in making sure that this project was as successful as it could be. But obviously, there are limitations to that. And due to the high volume of staffing changes in the month, it was inevitably not obviously implemented correctly by all staff members. The retrospective chart review was also a limitation due to the fact that many people have completed advanced directives, and unfortunately, human error, the nurse just wouldn't or didn't mark it in the electronic medical record properly, and obviously we would miss out on that data. The sample size obtained was also not the minimally acceptable number, as previously discussed. Generalizability was also affected, as this study was on a pretty specific population on a medical telemetry unit, and one of the requirements for inclusion was that they had to have a cardiac condition. So being that this is a medically unique population, that would have not have been as easily compared to a larger population of individuals that, let's say, don't have cardiac conditions or have kidney issues, liver issues, things like that. It's just not as generalizable to that type of population. So this project was fortunately not expensive for the hospital to implement, and so they allowed me to do the printing of materials and things of that nature at the facility, which I'm wondering if they maybe thought it would help them save on future spending, because people who have advanced directive documents, throughout my research, I did find that they save hospitals and just healthcare in general quite a bit of money in unnecessary or not performing unnecessary or futile treatments. Time efficiency was also a very important consideration, as I kind of discussed previously, because they were already very short-staffed, and adding us just a short detour to their usual admission process was much more appealing to staff. Basically, what I had them do was just, they always have to ask about advanced directives as it is when a patient is admitted to their unit. So basically, if they did not have an advanced directive in that initial questionnaire, they just took a little short 5-minute detour to have that education conversation with the patient. Some staff nurses also reported that they desired to continue to use this education format, and that this study actually made them more willing to have these types of conversations with their patients, because the education was right there. They didn't have to do any extra work, and it was so easy to understand too, which was huge. And I think that also really helps to improve the quality of care that nurses are giving their patients and the patient and nurse relationship dynamic. I mean, these are really serious and, important conversations to have with, quite frankly, complete strangers. And I think that, having these types of conversations really helps develop that bond between the patient and the nurse, and can develop trust, which hopefully would result in the patients, completing those documents. The project intended to provide long-term effects and practice changes within the unit and eventually at the hospital and health system level by improving the way that both providers and nurses have conversations regarding advanced directives. This doesn't necessarily have to be specifically focused on just nursing. This is something that, providers can also have these types of conversations with their patients, because at least at the facility that I work at, they don't have a formal education on advanced directives for the residency, like the medical residents or just new hire physicians. And the nurses implementing the project stated that it not only increased their own understanding of advanced directives, but it caused them to pay more mind to the topic and want to have those conversations with their patients. And although it was insignificant, there was one more advanced directive completed in the study group compared to the control group. And with a larger sample size, I would like to think that would have yielded significant results. So the implications for nursing practice. So as far as I was able to determine, this was the first study of its kind to be implemented, at least at this facility, and maybe the first ever to have this specific type of study design with educating the patients rather than staff. No previous attempts to create a standardized education for patients regarding advanced directives has ever been created at this organization. And if this standard format continues to be utilized, it could increase the potential for more of these critical documents to be completed, and most importantly, end-of-life wishes for the patient to be followed. Increasing the understanding of nursing staff regarding what advanced directives are and how they can be utilized in hospitalized patients can lead to overall better understanding that can carry over into how they educate their patients. And patients will continue to require advocacy by their healthcare team when it comes to ensuring that their wishes for healthcare treatment are being followed. And of course, the most effective way to do that is to have advanced directives on file. So a provider can look directly at what the patient had said they wanted prior to becoming too ill to be able to say it for themselves and know that they're doing the right thing. And of course, it allows there to be a legal guide for providers on how to proceed with medical interventions such as CPR, organ donation, artificial nutrition, via the use of the healthcare proxy decision maker that the patient elects via these documents. So, in conclusion, a comparison of pre and post intervention rates of advanced directives were compared, and although it was not significant, the potential for improvement in study length and study design could prove to be the difference in significant results for the future. Future research on this topic has the potential to change healthcare policy in both nursing and medical education across the United States, which could lead in an increase in medical and nursing schools incorporating education about advanced directives into their curriculum, as well as incorporating medical and nursing education into different healthcare organizations. And the impact that increasing advanced directive completion rates in patients across the country will ultimately provide not only healthcare providers with the peace of mind that they are doing exactly what the patient wishes, but also just maximizing that peace and comfort for the families and, most importantly, the patients that are served. In terms of impact, this process has had a huge impact on my priorities for my patients when it comes to advanced directives. Right now, as an ICU nurse, this is something that I really am very passionate about. I was already passionate about this topic, and throughout this research that I've done over the last year, it really has solidified my passion and desire to continue to try to implement this concept wherever I choose to work as an advanced practice nurse next. And really the only thing I would do differently for this project is just to make the study period longer, just to be able to do a better statistical analysis and have more statistically significant results. So I will go ahead and open it up to the floor here. Post your questions, ask questions. I'd be happy to answer anything you would like to know about the process or just the project in general. And here are my references.